Alrighty, cerebral trauma. Head injuries are a very common childhood injury. It can be the leading cause of death and disability in childhood. You can have blunt head trauma, which is when the head is struck by an object or from shaking, in the case of shaken baby syndrome. You can have penetrating head injury, which is from things like stab wounds or gunshot wounds. Children ages 0 to 4 years of age are at higher risk of head trauma due to falls, due to shaken baby, and due to child abuse. Children ages 5 to 14 also at risk for falls. They have a risk of being struck by an object. MBAs, because they're always the passenger, or they can be hit, if they're the pedestrian. Children ages 5 to 14, it's most common for them. That's the most common age for pedestrian accidents and MBAs. Children ages 15 to 19 years, again, our risk is MBAs, struck by objects, falls, or assaults. The pathophys, it's basically the force of the intracranial contents that cannot be absorbed by the skull, and the musculo-ligamentous support of the head. The head is especially vulnerable to acceleration, deceleration injuries. A child's response is different because of larger head size in relation to the body and because of insufficient musculoskeletal support. You should know the difference of contusions and lacerations. So I will tell you the initial injury results from a coup, except the word looks like coop on your slides, but the P is actually silent, so it's called a coup. Or a contracoup, which is actually pronounced contracoup because again the P is silent, type of injury. Coup injuries result from a direct blow to the head. Contracoup injuries result from movement of the brain within the skull, i.e. shaken baby syndrome. So with TBI, or traumatic brain injury, there are actually two injuries. One is from the actual impact, the scalp injuries, the skull fractures, contusions, and hematomas. Then you can get a secondary injury from the primary injury. The secondary injury results from swelling, impaired cerebral blood flow, cerebral edema, decreased cerebral perfusion, and eventually cell death. Because of flexibility, the immature skull can withstand a greater increase in deformities before it fractures. To produce a skull fracture in an infant, force must be extreme. I'm going to say that again. To produce a skull fracture in an infant, the force must be extreme. I worked in the NICU. We had a mom one time drop her baby. She had holding the baby in her arms, and she dropped the baby down on the floor. You would think that was an extreme force. We did skeletal, full head-to-toe x-rays on that baby, head ultrasounds. That skull did not fracture. So when you see skull fractures in babies, somebody has absolutely tried to kill that child. They have beat that kid to no end. You better love on that baby for sure. In general, the faster the blow, the more likely there is to have a depressed fracture. Low velocity blows produce linear fractures. Depressed skull fractures cause pressure on the brain because the broken skull pieces are pushed inwards towards the brain. Most childhood fractures are linear though. Comminuted fractures are a combination of depressed and linear. They are suggestive of repeated blows and child abuse. Basilar skull fractures are very serious. 80% of them result in bleeding into the posterior neck and mastoid process, known as the battle sign, bleeding around the eyes, bleeding around behind the eardrum, or leaking CSF fluid from the ear or the nose. Open fractures, they're open. It's a huge high infection risk. They need antibiotics like 2 weeks ago if they have an open head injury, like an open skull fracture. And then growing skull fractures, these are associated with an underlying condition such as a leptomeningeal cyst, dilated ventricles, or herniated brainstem. Complications from head trauma, epidural hemorrhage. This means the brain is forced downward as it expands, presents as a period of unconsciousness, then normal, then lethargy or coma. Subdural hemorrhage is another complication. Most of these occur in infancy. These develop slowly and spread thinly, and they're widespread. They can occur from birth trauma, from falls, from shaking. Presenting symptoms include irritability, vomiting, increasing head circumference, bulging fontanelles, lethargy, and seizures. To fix it, they're going to do a subdural tap. The third complication from head trauma is cerebral edema. This is kind of expected about 24 to 72 hours after an injury. Results from either injury to the cells, which causes intracellular swelling, because we know that when cells are injured, right, they swell, or results from a vascular injury that causes intracellular swelling. Either way, the result is increased ICP and changes in cerebral blood flow. Detecting TBI. Number 1, ask questions. Did the child fall? What did they fall from? What was the height? What was the surface that the child landed on? Did the child ever lose consciousness? For how long? Did the child have a seizure or did they vomit? TBI management. Maintain airway. You want to maintain the pulse ox greater than 95%. O2 is needed. You may be providing supplemental O2. You may be managing that airway if the child is on a vent. Either way, airway. You're going to monitor your cerebral perfusion and ICP. You want the ICP to be 20 or less. With increased ICP, the brain shifts inside the cranium and it can herniate. Recall, hypoxia and hypercapnia do not help the situation at all. In fact, they make it worse as it causes vasodilation and even higher ICP. Patients really should have continuous capnography. Treatment for increased ICP starts when the ICP reaches 20 or greater. If there is no C-spine injury, then raise the head of the bed up 30 degrees to facilitate drainage through the jugulars. Keep the head midline. Surgery may include taking out a lesion, decompressive craniotomy, burr holes, because we got to decrease that pressure somehow. Catheters may be placed to drain the CSF. Head cooling is sometimes used to try and treat and decrease the metabolic demands, which may help prevent brain damage. For shock, keep the head of the bed flat until adequate cerebral perfusion is obtained. You may have to give blood pressure support meds if cerebral edema sets in. You will give fluids to maintain blood pressure in a normal range for the child's age. Submersion injury, aka drowning. This is a major cause of accidental death in children. It seems like every summer on the news we hear of at least one child dying in a drowning accident. So basically what happens is hypoxia. Hypoxia damages the brain, the lungs, the heart, the kidneys, the liver, the GI system. Cerebral hypoxia is really bad. So in drowning there is hypoxia, aspiration, and then hypothermia. Irreversible brain damage occurs 4 to 6 minutes without oxygen. Remember, I told you guys the brain is really fussy about its O2. It's very demanding. It has to have it or it just starts shutting down everything else and cells start dying. The heart and lungs can last for 30 minutes in hypoxic conditions. Water in the lungs leads to pulmonary edema, atelectasis, airway spasm, and aspiration. This leads to impaired gas exchange. Hypothermia is a risk because of the large surface area in comparison to the body mass. Management. Emergency resuscitative efforts at the scene. Management is going to be based on the degree of the cerebral insult. Aspiration pneumonia is a very frequent complication. Hospitalization for observation at minimum if the child survives. Prognosis is the best indicator is actually the best predictor for a positive or a negative prognosis is the length of submersion. All right, you guys thought we were done talking about pediatric cancer. We're not. Now let's talk about nervous system tumors. You can have infratentorial, located in the cerebellum and the brainstem. You can have glial or neuronal, or you can have supratentorial, which may basically occur in the cerebrum. Brain tumors and neuroblastoma are derived from neural tissue, hence neuroblastoma. CNS tumors account for approximately 20% of all childhood cancers. CNS tumors are difficult to treat and the survival rates are poor. Brain tumors are the most common solid tumor in children. They can arise from any cell in the brain or spinal cord. Infratentorial tumors involve, I already told you that, never mind. Sorry. Therapeutic management, again, we're looking at chemo, radiation, surgery, depending on what the tumor is and where it's located. Radiation is generally avoided until age of 3 because of the rapid brain development that occurs from birth until 3 years old. Chemo generally produces fewer negative neurocognitive effects in children. The hard part with chemo and treating tumors in the head is trying to cross the blood-brain barrier. So they use very specific chemo drugs that can get past the blood-brain barrier in order to be therapeutic. Not just any old chemo will work. Again, the prognosis depends on the size, the extent of the disease, the age, the surgical resectability, all those things. Despite best efforts, children with brain cancer generally will have significant physical, cognitive, and endocrine effects because of the treatment. Neuroblastomas are the most common malignant extracranial solid tumor of childhood. Majority of these tumors develop in the adrenal gland or the retroperitoneal sympathetic chain. Other sites also include the head, the neck, the chest, and the pelvis. Metastasis may have already occurred before a diagnosis is made. Meningitis. In most cases, bacteria in the blood spread to the CNS where it enters the subarachnoid space, leading to an inflammatory response. Bacterial endotoxins cause the brain to swell, leading to cerebral edema, which results in anoxia, vasodilation, and increased ICP. The ventricles can get obstructed, leading to hydrocephalus, and it can trigger SIADH. Meningitis is going to be diagnosed with an LP. The lumbar puncture will likely show increased white blood cells, decreased glucose, and elevated protein. Most children with meningitis are very likely to have increased ICP. You will get a positive, if they truly have meningitis, you generally should get a positive culture from the CSF. Meningitis can occur secondary to otitis media, sinusitis, pharyngitis, cellulitis, pneumonia, septic arthritis, brain trauma, or any other kind of neurosurgical procedure. That's why infections in the head are very serious. In children, it is usually bacterial invasion from the middle ear or nasopharynx that end up causing the meningitis. Droplet infection from it can also occur from droplet infections from the nasopharyngeal secretions. Common culprits. Hib and strep pneumoniae are less common now due to vaccinations. Group B strep and gram-negative enteric bacilli are more likely to cause meningitis in newborns. Signs and symptoms of bacterial meningitis in infants. Fever. Remember how I told you infants don't run fevers. If infants run fevers, it's a bad sign. Changes in feeding pattern. I stressed that to you guys before. When babies change, when they stop eating, when they sleep through feeds, when they start spitting up all their food, something is wrong. Vomiting, diarrhea, anterior bulging fontanelle, or if it's completely flat, but usually it's going to be bulging. Babies that are difficult to console. Rocking or cuddling just makes them scream even more because it irritates the meninges in their brain. Look, signs and symptoms for children. They look remarkably a lot like those of an infant, except that I left out the rocking and the cuddling part. Hemorrhagic rash. Meningococcal infections have a very distinct rash. Signs and symptoms in children, again from meningeal irritation. Children may complain of a frontal headache, photophobia, which means they're sensitive to light. They may have inward eye deviation, nuchal rigidity or back pain. They're comfortable only in a certain position, and I'll show you what that is on the next slide. And then they have either a positive Kernig or Brudzinski sign. See how this child in the picture has flipped over onto her belly and she is arching her neck backwards? That's what this sign looks like. Kernig's sign, you want to raise the child's leg with the knee flexed. Then extend the leg at the knee. If any pain or resistance is felt, then it's a positive sign. This is a common finding in cases of meningitis. For a Brudzinski sign, you want to flex the child's head while laying on their back. If this makes the hips flex involuntarily, then that's considered a positive sign. This is another common finding in meningitis. Treatment. Obviously, labs and cultures, blood, urine, CSF, all that's going to be done. You'll want to collect all that stuff first. Then you will start IV antibiotics for 21 days. The child may need steroids, anticonvulsants, and antipyretics, IV fluids, management and monitoring for increased ICP. This child needs to be in isolation, droplet and contact until the organism is identified and it's proven that effective treatment is being given. Sadly, children with bacterial meningitis may be left with severe neurological deficits, such as hearing impairment. This occurs in 30 to 50% of cases of pneumococcal meningitis and about 10 to 30% of Hib meningitis and 25% of meningococcal meningitis. So, again, these things happen. And I hate to say, I said a couple of slides ago that there's not as much meningitis due to Hib and strep pneumoniae due to vaccines. However, I think that the tides are going to start turning because we have so many parents who are opting out of vaccinating their kids these days. So we may start seeing more things like this again. Viral meningitis is also known as aseptic meningitis. I hate that because aseptic sounds like it's not a big deal. I mean, aseptic technique is you try and make it as clean as possible. But aseptic meningitis, I just hate that. But it's also known as viral. When children are admitted, they will be treated as if they have bacterial meningitis because it's so much more severe until the PCR lab on their CSF comes back and says that it's viral. These children with viral meningitis often have an abrupt fever. It can shoot up to 104. They're going to have all the classic signs of meningitis. Seizures are rare. And again, I mentioned that PCR test, but they'll do, it's a polymerase chain reaction is what PCR stands for, of the CSF. And treatment is just supportive because if it's viral, antibiotics are not going to help us, right?